Welcome to Paals, the science anatomy lecture series. In this place, our goal is to make anatomy simple. If you are just joining us or you have not subscribed, we would like you to subscribe now and be part of this amazing anatomy family. In this place, we make anatomy simple. This is the part 2 in our series of lectures on the median nerve. In this section, we'll be discussing median nerve injuries and the associated clinical correlates. So let's go to class. At the beginning of our lecture in the part 1 of this series, we asked a number of questions. The first question we asked was, why is median nerve called leverous nerve? Now I think we are ready with the answers, having gone through the branches and the distribution. So it is because the coarse muscles of the hand required by the laborers, that's to dig, to lift, and do all those manual works, are actually performed by long flexors of the forearm. And these muscles are supplied by median nerve. We also ask, why is this nerve also termed the eye of the hand or peripheral eye? So let's go to the answer. A number of times you want to know how thin or feel the texture of fabrics. I'm sure you remember the fingers you used to do that. Your thumb, the index, and the middle fingers. And which nerve actually supplies the skin of this digit? You're right, median nerve. So a number of times we use this to actually see things by the feeling of the clothing, feeling of the fabrics. That's the median nerve doing more than our eyes would do, being additional eyes to the things we want to see. A number of times we button our clothes, and do you know how we do them? We don't look at them. We use the thumb, the index finger, and the middle finger. And we fix them correctly. They guide us even when we're not seeing them. This is why the median nerve is also called the eye of the hand, because it does all this work for the eyes. Now we are set to look at the lesions that affect median nerve and the consequences. Several things can cause median nerve palsy, and some of them are rare, while some of them are not. So some of the causes of median nerve palsy in the arm, one, they are rare, and usually it comes as a result of cut injury. Now, at the level of the elbow, the major causes are, one, supracondylar fracture of the humerus, and then sometimes dislocation of the elbow can also cause median nerve palsy. Whenever we have median nerve palsy coming up from the forearm and the wrist, it usually comes as a result of cut injury. The most common point of injury to median nerve is actually at the level of the carpal tunnel. This is where we see the median nerve passing between tendons of muscles running from the forearm to the hand. And here we have compression of the nerve by these adjacent structures. So let's look at the types of palsy. We have two types of median nerve palsy. When this palsy or injury occurs at a level in the arm and proximal half of the forearm, we call such injury high median nerve palsy. But when the injury occurs at a distal part of the forearm or at the region of the wrist, we call such median nerve injury low median nerve palsy. We're going to start with the high median nerve palsy. In high median nerve palsy, we know that at this point, median nerve is yet to give out any branch. So when we have lesion at this level, it will affect all the muscles, it will affect all the skin areas supplied by median nerve. In the forearm, we see a number of these muscular branches supplying these muscles, like the flexor superficialis, the lateral half, and we have the flexor carpi radialis, pronator teres, palmaris longus, flexor pollicis longus, and pronator quadratus. This actually, median nerve is actually the major nerve supplying muscles in the forearm. Now, in the hand also, we see this loaf muscle. What are those loaf muscles? For a mnemonic, they are the lateral two lumbricals. They are supplied by the median nerve in the hand. We have the opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis, which are all muscles of the thenar compartment. So we actually call them the loaf muscles. So all these muscles will be affected. Now, when we look at the sensory loss, every part of the body supplied by median nerve in the skin areas will also not feel these sensations. We have three parts in the hand supplied by the median nerve. The first part is the lateral to third of the palm, and here is that lateral to third of the palm. This is the lateral to third of the palm, and then this part supplied by median nerve will lose sensation. That will be sensory loss. We also have this cutaneous area too, which are the lateral 3.5 fingers. So this lateral 3.5 fingers, this lateral 3.5 fingers, also will not have sensation. And finally, the third part, cutaneous area of median nerve, is the distal phalanges of the lateral 3.5. That is the area we are seeing here. This is the half shared with ulna, and this is the half. So there will be sensory loss in these areas that are actually innervated by median nerve. We will now take bit by bit and see the effects on the various muscles in this high median nerve palsy. One, we are going to have weakness of flexion of wrist. And if you remember, it is the flexor carpi radialis and palmaris longus that actually help in wrist flexion. There will be weakness of this activity. Now, we also have loss of pronation. And if you remember, the two main pronators are actually innervated by median nerve. What are those pronators? The pronator teres and pronator quadratus. We will also have loss of flexion of the middle phalanges, of the index and middle fingers. Why are we having loss of flexion at this point? Because of the paralysis of flexor superficialis that will cause flexion of all the proximal interphalangeal joint alongside the flexor profundus. We also have the loss of the lateral half of flexor profundus. So with the loss of these two muscles, we're going to have loss of flexion of the middle phalanges of the index and the middle finger. Also, as a result of the paralysis of the lateral half of the flexor profundus, we are going to have loss of flexion of the terminal phalanges of the index and middle fingers. Also, in this paralysis, you will notice there will be loss of flexion of thumb. And this is because the two muscles that flex the thumb will be affected in median nerve palsy, high median nerve palsy. These muscles are the flexor pollicis longus, which is supplied by the anterior interosseous nerve in the forearm, and also the flexor pollicis brevis, which is one of the thenar muscles. We also remember that the external muscles are also innervated by the median nerve, the recurrent branch of the median nerve, which is a branch from the lateral division. So the thumb will be hyperextended. As you can see here, at this point, there is hyperextension of the thumb at this point here. We'll also notice there will be loss of opposition of the thumb because the opponent pollicis, which is one of the muscles of the tender eminence, will also be lost. So there will be loss of opposition of the thumb, and this candidate will not be able to do opposition, and then will be unable to do this OK sign, as you can see in this. As a result of the loss of innervation to the tender eminence, there will be atrophy of all the muscles in the tender eminence. These tender muscles will atrophy and will look like this. Now here, the muscles have atrophied because of the loss of nerve supply from the median nerve. This atrophy will lead to this characteristic deformity in the hand, which is called the ape hand. So this is the hand that is called the ape hand because of the atrophy of the tender eminence and then the hyperextension at this point. And here, because the abductor is also lost, the adductor pollicis here will also push the thumb in a fixed adduction position. Now we also see loss of cutaneous sensations on those three areas of median supply in the hand. And we're looking at the lateral to third of the palm. We're looking at lateral to half fingers. We're looking at the distal phalanx of the lateral 3.5 digits, which are these ones. So we'll look at clinical presentation of this median nerve injury. One is the loss of all these muscles we've noted, as we can see them here. We'll also see sensory loss in those three areas of median nerve innervation in the hand, as we can also summarize here. And we'll see this characteristic deformity of ape-like hand. We will now consider the median nerve palsy. As we reported earlier, this is injury at the distal part of the forearm or at the wrist. When this happens, nerve supply to flexor psoas superficialis, flexor psoas profundus, and flexor pollicis longus are intact because at this level, these muscles have received their innervation. So low median nerve palsy will spare these long flexors, all of them. So the rest of the muscles will be affected the way they are affected in high median nerve palsy. One of the points we noted that median nerve could be damaged or compressed is at the level of the carpal tunnel, and within the carpal tunnel we noted the position of the median nerve in between several tendons. So when there is compression of this nerve in the carpal tunnel, we will see slight flattening of the tender eminence, and this is due to wasting of the muscle of tender eminence, which as we said are supplied by median nerve. Now, this will also be followed by burning pain or pin and needle sensations, and also diminished cutaneous sensation. And this is seen on the palmar aspect of the lateral 3.5 fingers. Now we will see loss of sensation over the tender eminence. Why? This is because the nerve supplying this area did not pass through the carpal tunnel and will not be affected with this compression. And the nerve that did this is the palmar cutaneous branch of the median nerve. In this section, we will consider all the various tests that are used to assess the various muscles that could be affected in median nerve palsy. We'll start with a test for flexor functions of the flexor digitorum superficialis and profundus. We have two tests. The first one is the Oschners clasp test, and then the second one is also called the Benedict test. We will start with the Oschners clasp test. In Oschners clasp test, which is also called the pointing index finger test, when the patient is asked to clasp both fingers the way we can see in our illustration here, if this patient has median nerve lesion, the index finger of the affected hand will not flex, as we can see from this illustration. This finger will remain pointed, and this is due to the loss of the two principal flexors that have flexed its proximal and distal IP joints. This is why this finger is remaining pointed, and this is positive for median nerve lesion. The second test for these long flexors of the finger is the Benedict test. Here, when the patient is asked to make a fist in the suspected hand, the middle and ring fingers will remain extended. As you can notice from this illustration, this patient has been asked to make a fist, and we can notice that only the little and ring fingers were able to flex. This is as a result of the loss of the flexors for the index and middle fingers. Now, why are we having the little finger and ring finger flexing? It is because they are long flexors that are innervated by the ulnar nerve are still intact, because this lesion is only affecting the median nerve. So this hand gives the appearance of a priest trying to bless the people, giving the reason for the name, the Benedict test. And this is positive for median nerve lesion. The next test is the OK sign test, which is also called the pinch sign test. This test will assess the functionality of two muscles that are supplied by the anterior interosseous nerve, and those muscles are the flexor digitorum profundus and flexor pollicis longus. This condition will arise: the anterior interosseous nerve supplying the flexor digitorum profundus of this finger is affected, and also if the median nerve supplying the flexor digitorum superficialis in the proximal IP joint is also affected. Now here also, the flexor pollicis longus, which is innervated by the anterior interosseous nerve, when it's affected, will also give rise to inability of the thumb to be flexed at this IP joint. This patient will not be able to flex this joint and will be unable to make the OK sign. When this patient tries to make this OK sign, this patient will give a shape like this. In the pen test, this test will assess the abduction function of the abductor pollicis brevis. Abductor pollicis brevis is one of the tendon muscles and is also supplied by the median nerve. In this test, the patient will be asked to put the hand on a flat table with the palm facing upwards. This patient will be asked to abduct the thumb so as to touch the examiner's pen. As you can notice from this illustration, this is the suspected hand, and then this is the examiner's pen brought very close to the thumb, such a way that the patient will need to abduct the thumb to reach the pen. Now, inability to do this is positive for median nerve lesion, where the function of the abductor pollicis brevis has been impaired. In this section, we will have a brief look at some of the compartment syndromes that can be associated with median nerve. We have three of these syndromes, and they are: 1, the pronator syndrome; the anterior interosseous syndrome, and the carpal tunnel syndrome. Having considered carpal tunnel syndrome in our earlier lectures, our focus will be on pronator syndrome and anterior interosseous syndrome. Pronator syndrome is also called pronator teres syndrome. This occurs when the median nerve is compressed in the upper part of the forearm. Now, this compression can occur in 3 sites, and we call this site the entrapment site. This compression can occur in 5 potential sites, and we call them potential sites for median nerve entrapment. Now we have the first site being at the point of supracondylar process, where we see a projection from the supracondylar region of the lower part of the humerus. We can also see the ligament of strata, and then we also see this at the bicipital aponeurosis. This can also happen between the ulnar and humeral heads of pronator teres, and finally, this can also happen at the aponeurotic arc of the flexor deuterum superficialis. We will start with the supracondylar process. Now, in this illustration, this is the lower part of the humerus, and here is the medial epicondyle, here is the lateral epicondyle. Here is the supracondylar region. Now, when we have this process called the supracondylar process, it creates a potential site for median nerve entrapment, as you can also see here, the median nerve running deep to this process. When we also have a ligament running from this process and getting inserted into the medial epicondyle, this ligament will be called the Strotter's ligament or ligament of Strotter. So this ligament will also create additional points of entrapment for the median nerve. The third point for this median nerve entrapment is at this point of bicipital aponeurosis. Here is the bicipital aponeurosis. As median nerve runs deep to this aponeurosis, as it enters the forearm, it can be entrapped in this space. The next point for this entrapment is between the humeral heads and ulnar heads of pronator teres. In this illustration, we can see the humeral head of pronator teres, and distally here, we can see the ulnar head of pronator teres. And between this humeral head here and the ulnar head here, we see the median nerve running between them. And this narrow space is a potential point for median nerve entrapment. Now we have the last point for this entrapment, which is this aponeurotic arc. This aponeurotic arc in this diagram is actually formed by the flexor deuterum superficialis. And then we see the median nerve running deep to this aponeurotic arc, creating a potential point for its entrapment. Anterior interosseous syndrome is actually a pure motor neuropathy, and it will affect the motor functions of the 3 muscles that are supplied by the anterior interosseous nerve in the forearm. Anterior interosseous nerve, remember, is one of the branches of median nerve. Now here, this is a deep dissection of the forearm. In this dissection, on this lateral part, we'll be seeing the flexor pollicis longus. And then on the medial part, we'll be seeing the flexor deuterum profundus. Now distally here, we'll see the pronator quadratus. So we will see the anterior interosseous nerve running between the flexor deuterum profundus and then the flexor pollicis longus. Now this nerve supplies these 3 muscles. This syndrome will come as a result of compression of anterior interosseous nerve, or neuritis of this nerve, or trauma to this nerve. The most common site for entrapment of this nerve is actually at the tendinous edge of the deep head of pronator teres muscle. Here again is the deep head of pronator teres, and this is the superficial head or the humeral head. Now, at this point of the deep head, we see the anterior interosseous nerve being given off from its main branch, the median nerve. And this point is a potential point for entrapment of this nerve. Anterior interosseous syndrome is characterized by inability to flex the distal interphalangeal joints, as you can see here, when the flexor digitorum profundus is paralyzed, and here when the flexor pollicis longus is paralyzed, because both muscles are the only muscles that will flex the distal interphalangeal joint, and these muscles are innervated only by anterior interosseous nerve. So when we have anterior interosseous nerve syndrome, these muscles will not be able to function, and this patient will not be able to make this OK sign, and then we'll end up doing what looks like this. This is where we end this part of the lecture. If you have questions, comments, or suggestions, please drop them in the comment section. If you consider this material helpful, we will encourage you to subscribe, like the video, and share it to your friends, that it will also be helpful too. And together, we will build a unique anatomy family where we make anatomy simple. See you in my next video. And bye.